chapter, at least as best I could. With the first part, I will be honest, this one I'm going to be bouncing all over the textbook, areas that I haven't had an opportunity to cover or talk about yet. Plus, as is typical for me, I've added some stuff to it that's not found in the chapter.
No.
I know, shocker. But in case you're curious where I'm starting at, and I'll try to pay attention as I go through, where I'm starting at is found on page 766 from chapter 37, page 766, that talks about airway maintenance. And who's responsible for airway maintenance? Well, of course, we are. And our responsibility all listed here. And I'll hit most of these, some of these I'll just kind of briefly mention, because I know we either talked about them in the past or we'll be talking about them in the future. So securing the airway, of course, that's our responsibility to secure the airway not only initially when the tube has been placed, but throughout the patient's time with that endotracheal tube or tracheostomy tube. It is our responsibility to make sure that tube is secure. Not the physician, not the nurse, it is our responsibility. So if it looks kind of crappy, we may need to change how it's secured, whether we're changing the tape or changing the tube holder. Again, I know we talked about some of those tube holders yesterday. Providing communication. We know that the patient who's intubated or who's trached on the ventilator with a cuff that is inflated will not be able to speak. If it's an endotracheal tube, absolutely they will not be able to speak. The tracheostomy tube, I know we mentioned briefly the other day about putting a speaking valve, so they might be able to communicate with us, but generally speaking, most patients who are going to be intubated or trached will not be able to talk to us. That being said, many times we need to kind of help them with communication, whether it's a thumbs up or thumbs down, whether they can write something out for us, and sometimes they will. Sometimes they will want to try, but as far as our ability to read what they've written could be poor, depending how long they've been intubated, how long they've been kind of in that position. I say lip reading. I'll be honest, I'm not the best lip reader in the world. I always, if the patient's really trying hard to communicate with me, and I'll try to read what their lips are saying, or if I'm with you guys, I'll say, here, come figure out, see if you could help me figure out what he's trying to tell me. Or the nurse, or the ACP, or someone that might be a little bit better at it than, say, I am, or say you are. But sometimes you can get through if they're just trying to say a single word or something like that. But when you know someone's trying to communicate with you and they can't speak, I'll start with the very basics. Are you too hot or are you too cold? That may mean, hey, take some of these damn covers off me, or give me another blanket, I'm freezing. Another one, are you in pain? You know, and if possible, can they point to where the pain is? What's hurting? Those are just some very simple things. Like I said, they could perhaps write us a message. I've had patients that I've given a clipboard and a pen to with a piece of paper, and they try, bless their heart, they try, and there's no way to read what they're trying to write us. They're just not strong enough, physically capable to write us a message. Sometimes these letter boards or phrasing boards, they can point to certain things, certain phrases, or maybe even spell some things out for us if that's the case. Funniest thing I've ever seen a patient try to communicate with me. I gave them a clipboard, a pen, a piece of paper. Can you write? I can't understand you, sir. Can you please write down what you're trying to tell me? He spelled out the word Budweiser. I think he wanted a drink. It made me laugh. I laughed out loud. I'm sorry, we cannot provide that, but the second we get that tube out, we'll see what we can do. I'm not a bartender, but I'll ask the nurse. He or she may be able to help you with that. They won't. I said speaking valve for a trach patient. So again, giving these poor folks an opportunity to try to communicate with us. And I know it's hard. I know it's frustrating for them. It's frustrating for us because we can't make out what they're trying to tell us. All right, a few things. Ensuring adequate humidification. We'll get to that in the next chapter next week that we're going to be discussing. So I'm not going to spend any time on that, but we do need to provide adequate humidification if we have someone with a bypassed upper airway. Minimizing nosocomial infections, of course, doing the proper hand hygiene and hand washing and foam in, foam out type things, of course. One thing, and we'll get to this in due time, about not disconnecting the patient from the ventilator circuit. Sometimes we have to, but generally if we can avoid that, that's going to be better for the patient to minimize acquiring any sort of hospital-acquired infection. I didn't catch this until this morning. If your slide says adding secretion clearance, it meant to say aiding secretion clearance. I'm going to say damn spell check. It changed my word. That's my fault. I'm sure I typed that in adding instead of aiding. So my apologies there. I fixed it on my screen, but I know the PowerPoint that I uploaded says adding secretion clearance. How about just aiding in secretion clearance? We know about the closed suction catheter system. Some therapies we'll talk in the coming weeks. Bronchial hygiene therapy, which we can still perform to kind of aid or assist secretion mobilization, which would help us then suction and clear them out. Everybody remembers this from seeing it and handling it last Friday. Closed suction catheter is inside that protective sleeve. Do you have to wear sterile gloves? No, you do not have to wear sterile gloves. This end here will be connected to what? The patient's trach or endotracheal tube, because again, I need a straight shot to get down to the airway. I don't remember if my group and I talked about this. I don't know if Desmond and his group talked about it. Where does this part connect to?
The ventilator.
The ventilator circuitry. So the ventilator is delivering the breath that's coming through here and going to the patient. Again, suction catheter, what does this end connect to? My suction tubing, my vacuum tubing. There's my trigger to sit there and depress and create vacuum or to create suction. We talked about the other day about the cuff pressure, excuse me, and making sure we maintain an appropriate cuff pressure, and we're constantly checking it. And I gotta tickle my throat. The cuffs we will be using are known as high volume, low pressure cuffs. High volume, low pressure cuffs. If I give you a test question and I say, do you want to select the low volume, high pressure cuff? You're going to tell me no, that's not what we use. And the reason I'm telling you this, the MBRC likes to just flip-flop the verbiage. Low volume, high pressure, no. Think about a respiratory care. We don't want anything high pressure. So make sure high volume's okay, but keeping the pressures low. So high volume, low pressure cuffs. These have a much larger surface area, which kind of helps to spread out any sort of pressure being exerted on the tracheal wall versus some of these older style high pressure cuffs that, especially in this area, would create significant amount of pressure and perhaps blocking mucosal blood.
Is that one and the same? It's just called that?
These are two different types of cuffs. Low volume, high pressure.
I meant the high volume and low pressure cuffs. That's two different ones.
No, that's the same.
It's the same one?
It's the same.
Okay.
You want to be able to provide higher volumes inside that cuff, but at the same time exerting low pressure on the tracheal mucosa. I said goal here is to keep pressures less than tracheal mucosal capillary perfusion pressure. Again, think about the tracheal wall. But at the same time, keeping the pressure high enough to not allow air to leak back around the cuff. So if this is the tracheal wall here that is pictured, that's how I want the cuff to sit inside that tracheal wall, occluding any air from leaking back up or anything from leaking back down from an underinflated cuff. So the cuff should do what? Seal itself into the airway. Cuff pressure numbers, same as I shared the other day, somewhere between 20 and 30 centimeters of water pressure. As the respiratory therapist, we should check those cuff pressures regularly. Every hospital is going to have their policy on what sort of frequency that's going to be. Some it could be every 6 hours, every 12 hours, every 24 hours. So in those instances, we'll abide by whatever the hospital policy is for checking that, but it should be checked fairly regularly. The term MOV and MLT, your textbook refers to it. They don't really do any defining of what those are. And I almost wanted to just pull that out just because it's something that is currently not an acceptable way, but I'm going to mention it because it is a way folks will still add air to the cup. So I'm just going to define it, explain what those are. But I want you to remember, in our world now, we should just be checking cup pressure. We should be checking cup pressure. So let me explain. MOV stands for minimal occluding volume. Minimal occluding volume, which simply means this. When you add air to the cup, you add enough air to where you do not hear any air leaking back up through the mouth. I'm going to take my 10, 12, 15, 20 cc syringe, whatever syringe I have available. When the tube's placed, obviously initially we'll hear air leaking back up because the cup hasn't been inflated yet. I'll start to add air to the cup. Once I hear no air leaking from out the mouth, I stop adding air. Minimal occluding volume. Now notice, I don't know how much pressure I'm exerting on the tracheal wall. It's why it's not currently recommended to be done that way. Because I don't know what the pressure is. I just simply added air, and I think I've sealed it in the airway, but could I have over-sealed it in the airway? Possible. That's MOV, minimal occluding volume. MLT stands for minimal leak technique. Minimal leak technique. Which the procedure to do the minimal leak technique is exactly the same as MOV, but with one added step at the end. So MLT, you add air until you hear it sealed in the airway. No air is leaking back up through the mouth. Then what you do is you take your syringe and you begin to remove just a little bit of air until with your stethoscope attached to the patient's neck, you hear a slight air leak during inspiration. At the time, it was thought of, well, the MLT is better than the MOV because you're still adding air to seal it in the in the airway, trachea, in the airway, but you're removing a little bit of air to not overly exert pressure on the tracheal wall. Okay, so at the time it was thought MLT is actually a little bit better. But what happens if I do hear a slight air leak during inspiration? That means some air is coming back up around an underinflated cuff, which means anything that could be found above the cuff, secretions, oral secretions, could find their way down. And so was never the best way. There was always the third way, check the pressure, check the cuff pressure. And that was always the third way. And so all three were equally acceptable, but we've gotten smarter, we've gotten better with, shouldn't we just check the pressure? If we check the pressure, then the MLT, MOV really doesn't matter, it doesn't make sense anymore. And so that's why the textbook says MOV and MLT, and I think they just use the initials. I don't think they even define what that stands for, but said shouldn't be recommended. Again, increased risk for silent aspiration. Aspiration, anything that could be in the mouth, oral secretions, could find their way down, because remember, the epiglottis is not closed, it's open because there's a tube down there. Could find its way down here, and then get past the cuff. And again, lead to perhaps an aspiration pneumonia. All right, everybody okay with that part? So what's the purpose of the cuff? To keep a seal, to seal that tube in the airway. Now it's real important that we're using the right size tube, because then we won't have to exert too much or add too much air or exert too much pressure. And so even though I just said that as long as you maintain this cuff pressure, it'll seal it, the tube will be sealed in the airway, and nothing technically should get past it. right? Nothing that's above it should technically get past it. However, we know that that's not entirely true. The cuffs do develop channels inside of them, and that over time, and this is kind of an experiment in a clear tube so you can see it. Endotracheal tube, here's the cuff, here's the cuff. They put fluid, blue colored fluid, and they wanted to see if any of that stuff got past, even though the cuff is inflated here. I know it doesn't look like the cartoon picture previously, but it is inflated enough to seal itself in this tube. And notice these little grooves, these little channels. So some fluid, some secretions that are above the cuff still can possibly find their way down and get below the cuff, meaning now there's fluid, oral fluid in our mouth getting down and getting into the lungs. That's why we've learned with the prevention of VAP, the better oral care, better mouth care, making sure bacteria doesn't form here, less chance of bacteria, microorganism, to get down and get into the lungs. All right, here's a question for you. The respiratory therapist is called to assist with a 220-pound, 6'2" male patient who's intubated with a 7.0 endotracheal tube and is receiving positive pressure ventilation. The patient's nurse reports to the RT that over the past week it's been increasingly difficult to get a good seal with the tube cuff, and that she has had to add more and more air to prevent gross leakage. They keep hearing air leaking back up through the mouth. When asked if the cuff pressures have been monitored, she says no. What is the likely problem, and what would be your solution? What's the issue here? Connor?
Could the cuff have a leak in it?
Okay, possible. Possible the cuff has a leak in it, so that's the air we're hearing kind of, or air that's coming back up, that's coming back from an underinflated cuff because there's a leak in the cuff. That's possible. Necrosis, from it being like this for so long and now tissues breaking down. Possible.
Maybe since the cuff pressure is never monitored, they never got a good initial seal. I don't know, I guess
Maybe.
it says that.
Okay, maybe. All those sound, everything you said sounds legitimate.
Too
Right.
small? Yeah, the tube might be too small.
Too small. What's too small? The ET tube. Anybody catch that? Obviously some people caught that, right? 220 pounds, 6'2" male patient with a 7.0. A male patient should be intubated with a 8.5, technically, right? 7 is a very small tube. And so I'm exaggerating here, if the patient's airway is this wide, and you put too small of a tube in, how much air are you going to have to add to seal it? You're probably adding a lot of air. So it can stretch out and try to seal itself into the airway. But that's because you intubated them with too small of a tube. You intubate them with a correct size tube, you will not have to add as much air as they were in this example. Because what is happening? They did add air, but over time, air is leaking back around. Notice how this is not touching the tracheal wall. This is leaking back up, and that's the sound they're hearing. Oh, we shouldn't be hearing sound coming out the mouth. It should only come back and forth in the tube. So let's add air to the cuff. Try to seal it. And it's going to continue to be a problem until what happens? We put the proper size endotracheal tube in place. Because if not, we're going to just keep adding air. Which at that point, if I'm adding so much air, I may turn that high volume, low pressure cuff perhaps into a high volume, high pressure cuff. But again, we don't know in this situation. And I know the RT seems to throw the nurse under the bus here. Hey, we should have been checking it too. We should have been paying attention and checking it as well. All right, so troubleshooting. This is the big thing for what we get called on. Everything's great when everything's doing and working like it's supposed to. But of course, things happen. Situations happen. We take over the care of a patient, and maybe the RT before was marginal at best. And now we're cleaning up their mess, and we're running into these issues or airway emergencies. And I do say airways emergencies because, again, We are providing their airway, whether it's a trach or an endotracheal tube, and if something happens to that airway, that's going to impact their ability to breathe. And I love this. What does a respiratory therapist do? Stop breathing, and I'll show you. All right, so emergency airway situations may occur like tube obstructions, cuff leaks, unplanned extubations. I'll tell you a whole bunch of stories about unplanned extubations here in a minute. Clinical signs that we would see is obviously the patient could be in respiratory distress, decreased breath sounds. If the airway's messed up, maybe not air can get to the lungs, so we will notice decreased breath sounds. Air movement, like I described just previously, air coming out the mouth when it should be staying inside that tube, among other things. But remember, in these emergent situations, we have to troubleshoot and correct things quickly. It's saying, well, if the patient can't breathe because of what's happening, well, how much time do we have for someone not to be able to breathe? And so it's not a matter of, well, let's call doctor and see if the doctor can figure it out. Doctor, no. If they're in the room, they're going to cause trouble. You know, we can figure it out. We can at least address the situation, figure out what's wrong, and remedy it. We might not be able to fix everything, but at least we could remedy the situation so the patient can still breathe. All right, tube obstruction. Scary, scary, scary when a tube becomes obstructed, because that is their airway. And if it's obstructed, if it's blocked, the patient will not be able to breathe. Tube obstruction is the most common of these airway emergencies. And so there's things we'll talk about to try to prevent them from happening so they don't become obstructed. First one here, kinking of the tube or a patient biting the tube. It can happen. It's not often, but it can happen. You've seen those endotracheal tubes. You'll see them again Friday. If you were to squeeze an endotracheal tube, it's pliable. You can clamp it closed, let alone if you bite down on it with your teeth, you can occlude it 100%. And sometimes you will have patients do that. They're madder in hell. I'm biting that tube. And now your ventilator's alarming, going crazy, you know, tapping the face, trying to be gentle. Stop that, quit biting the tube. There's things we can do to, for example, there's a product known as a bite block that can be placed on the endotracheal tube. It's a hard plastic piece that goes around the tube. And if the patient wants to bite, they're biting that hard plastic, but they will not be able to compress the endotracheal tube. We can even put in an oropharyngeal airway, and the patient's biting that, and they can't compress the endotracheal tube. But that's a few and far between occurrence. I don't want to say rare, because it does happen, but you know, maybe the patient needs some sedation or something to take the edge off or something like that. Obstruction of the tube orifice against the tracheal wall. Maybe it's just in a position where it's just touching the wall of the trachea. It's just slid to a certain position, because you know, the each tubes are kind of curved. Maybe it twisted a little bit, and it just happens to be resting up against the wall. That's okay. We can readjust that tube. That's not that difficult. Thank goodness we have the Murphy eye, that if the main opening was blocked on the wall there, at least we still have the Murphy eye to allow air to flow. But the third one, mucus plugging, that's the one that always gives us trouble, because a patient's going to have secretions. They're going to have difficulty clearing their own secretions because they have a tube down their throat. The glottis can't close to build up pressure for them to give a good, strong cough. That's why we have that closed suction catheter, why we're going down there so frequently, to get rid of that mucus that's been building up. When we suction the tube, we may have to even use normal saline to kind of lavage and try to liquefy a little bit better some of those secretions to make it easier for us to remove them. God bless you. We may have to increase that vacuum pressure, but going no higher than the recommended range, so 200 if it's an adult, 120 if it's a neopede. But if I'm not there yet, I have some ability to increase vacuum or increase suction pressure to be able to use that. They even have a mucus shaving device. Mucus shaving device that can be placed down the endotracheal tube. Now this is not going down into the patient's trachea, it's going down the endotracheal tube. And yes, I know that endotracheal tube's in a patient's trachea, but it's not literally going into their trachea, it's just staying inside the endotracheal tube. It's what it looks like, okay? It's gonna go inside of the endotracheal tube, still in the patient, still attached to the patient. There's gonna be a balloon on the end of it that we will inflate. We will then, once the balloon's inflated, begin to pull it back. Holding the endotracheal tube, because I don't want to extubate the patient yet, holding the endotracheal tube with one hand and pulling back this mucus shaving device with the balloon inflated. You know what that balloon's gonna do? It's gonna drag and grab the contents that are inside the endotracheal tube. One of my favorite pictures, you're gonna have something like this on the end of it. Okay, great, you got all that crap out of the inside of their endotracheal tube. You know what this is, or what this could form? A mucus plug. And if a mucus plug is occluding 100% of the endotracheal tube, guess what? Your patient can't breathe. Your patient's gonna have a tube that looks like this. That is loaded with mucus. This was a patient who had a nasty mucus plug. They could not get the mucus plug out. So what did they do? They extubated the patient, they took that tube out, and reintubated the patient with a brand new tube. And this is what they had pulled out. So this is the old tube. And so some dork like me says, man, I really need to show that to my students. Let's cut it so you can really see where the mucus plug is. And I do find this fascinating, aside from the grossness of the mucus, but this little blue thing, what do you think this blue thing is? That radiolucent line inside the endotracheal tube. And that little hole, what do you think that little hole?
That's for the air when you're.
Air for the cuff, that pilot line.
Yeah.
That is outside of the patient, and it has to, it's part of the tube. You know, we don't physically see this little line stuck on the outside. It's on the inside, but that's going all the way down to where the cuff is. Now, I find the picture fascinating. Again, if I could just take the mucus out of it, I'd leave it up here all day. But yes, but this is what a mucus plug looks like. It is completely 100% occluding that endotracheal tube. And again, if this is your patient, can they breathe? No, they cannot breathe. And maybe initially when I realize this is happening, I try to suction, I can't get anything, or maybe the catheter gets stuck. Oh no, I'm feeling resistant. I know I'm not at the end of the endotracheal tube. I'm about halfway into the tube. I'm not even in the patient to their carina. So it's not that I've gone all the way to the carina. I know I have a lot more tube to pass this catheter, and I'm hitting this.
So when using the shaving device, is there a risk of you pushing the mucus farther?
It's possible, it's possible. That's why you don't inflate the balloon until you get it through. Then you inflate it and drag it, and you can get that nastiness there. All right, cuff leaks. That's another potential problem. And if the cuff was to leak, if the cuff leaks, then I have air leaking back out the mouth. So even if they're on a ventilator, or if I'm squeezing that resuscitation bag, some of the air may be going to the lung, but probably most of the air is turning around and coming right back out. Again, path of least resistance when you're trying to give them that breath. If the pilot balloon or the pilot line is leaking, okay, if for some reason there's a tear or hole or something in here, the air that's in that cuff will leak back out. Again, there's not much air in here. It just takes a little bit, and now the cuff is going to deflate. Where that, and again, we would need to repair that or replace the entire endotracheal tube. They do make, and not every hospital has this, but they do make a product that they refer to as a pilot valve repair kit, where you can basically just cut this off and then attach the new one to it. It's a little needle on the end of it, and that little needle slides inside that pilot line, and it creates a tight enough seal. It's a temporary fix, but at least you can now still be able to now ventilate the patient again, because you can add air back to the cuff. But this is, and I don't want to use the word common occurrence, but I will say this happens. Where someone, I'm not pointing any fingers to anybody, but people who take care of those patients who have endotracheal tubes. People who are working here with that patient, which includes us, but there's others that work with the patient in this field. If they accidentally cut this, what happens to the cuff?
Deflate.
It deflates. Do we say that again? Okay. People that are just trying to cause trouble. No, I'm joking.
trying
by
to cut clothes off the
accident,
patient or
by
something?
accident. So, who carries scissors? Nurses. Yeah.
Everybody.
We carry scissors. There may be times we're trying to cut the tape or things that are there on the patient. Would happen more often when we used tape and not those tube holders, but if we're cutting the patient, oh no, we accidentally cut this. Okay, it can happen. It has happened. Patient. We may be nice, or the staff may be nice and decide to shave the patient's face. Okay? Well, what are they shaving them with? A razor. And as they're getting here, where this may be hanging out of the patient's mouth, that razor just nicks that line. It doesn't cut it in half, but just nicks that line to cause a hole. You're going to see that happen. And then suddenly, the ventilator's alarming, you're hearing air leak back around the mouth. You weren't even in the room, and they're calling respiratory, we need you here stat. Something happened, we don't know what happened, fix it. And you're like, oh, who sliced them with the pilot line? Because now this is deflated or in the process of deflating and air is coming back through the mouth. Again, something like that, you probably have to replace the tube because again, the pilot valve repair kits are possible, but things have to happen pretty fast. If there just happens to be a ruptured cuff, there's just a tear in the cuff, somebody overinflated it and popped it inside someone's airway, hard to think about, but if it happened, there's no way to fix that. You'd have to extubate the patient and be prepared to re-intubate the patient, or to call someone who can re-intubate the patient. Again, depending on our hospital and whose responsibility for intubation, sometimes it is the physician that has to come in and you have to call the physician to come in to re-intubate that patient. All right, unplanned extubation. So, and that simply means the tube's coming out prematurely. We didn't intend for it to come out, but it came out. It lost its position. A few different reasons here, a few different possibilities. Again, in no particular order, I'll say one of them was the RT that secured that tube or taped that tube. It wasn't a very good secured tape job, or tube holder was not put on well enough, and the tube became displaced out of the airway. Okay, so even though it may still be in the mouth, it's been displaced. It's been pulled out of the trachea. So it's in the back of the throat. You're hearing massive air leak. You're hearing massive amounts of air coming out of there. That situation, get rid of that tube. Be prepared to re-intubate that patient. Another thing could occur. Couldn't the patient, again, my story about being nasally intubated, and what that nurse tell me? Do not pull that tube. If you wake up and there's a tube in your nose, do not pull it. That was the first thing I did. I went to feel for it. I wasn't going to pull it, but I went to see if the tube was there. Do you think patients accidentally or intentionally grab that tube and go, I'm tired of this thing, I want this thing out, and they pull out their endotracheal tube with the cuff inflated? The cuff's in, because again, they don't know to take the air out, and I wouldn't give them a syringe to take the air out anyways, but they just pull. This tube's in my throat, it's irritating me, it's bothering me, I don't know what it's there for. They pull it out, cuff inflated and all. Where did that tube pass? Where did that cuff pass through? Those vocal cords. I always say this, look at the end of the inflated cuff. Is there any like butterfly looking thing dangling from the cuff? Did they pull out their vocal cords when they yanked that tube out? You know, take a look at the end of that tube. Yeah. You just learned a valuable lesson, patient. So what do you think we do with our poor patients who are intubated? Tie them down. They are restrained. We don't do it to be mean. We do it so they don't start pulling very important things out of their person, right? We also have to be mindful, even though, and it's typically the soft restraints that we tie them down with, and yes, it may look like we're being cruel and, boy, poor patient can't move at all. No, it's so they don't start pulling IVs and catheters and endotracheal tubes out of them. There's going to be times you may have to access the patient's arm or wrist, and so you may have to undo one of those soft restraints to be able to gain access to the patient. What should you make sure you do at the end? Put it back, re-restrain them, put it back. I know there's therapists that get busy and they took the right restraint off, they did what they needed to do, ran out of the room because they had to stick the patient for a blood gas in the right radial artery, and they went to go run the sample. Oh, patient, oh, look at what I can do. And there goes the tube. That suction catheter, the closed suction catheter. So again, the endotracheal tube sticking, say, yay far out of the patient's mouth. But you guys have seen it. How long is that suction catheter? Okay, that closed suction catheter. Am I exaggerating? Is it something like this probably? That's also attached to vacuum tubing going to the wall, going to the canister. If I let that just lie here, and a patient, even though they are restrained, couldn't they grab hold of that closed suction system or even the vacuum tubing and start to pull? I've walked in patients' rooms before and I see they're trying to pull. Stop that. Okay, so instead of letting that catheter lie over their abdomen and stomach, okay, let me throw it over your shoulder. So it's going that way. You can't grab hold of it there. That's another way where they can accidentally or intentionally extubate themselves, removing that tube. So never a good thing to have an unplanned extubation. We want everything to be structured and everything to be controlled. We don't want the patient to be extubated prematurely. All right, the concept here of extubation and decannulation. Tracheal intubation, or having that breathing tube in the airway, hopefully is temporary. It's only going to be in there for a certain period of time. Hopefully it's only temporary. And so at some point, we'll have to say, okay, are we going to extubate the patient, take that endotracheal tube out, or decannulate, take the tracheostomy tube out? So the patient has to be ready. We have to assess, are they ready for extubation or decannulation? The first one here, is their original problem no longer present? Is the reason we put that tube in the first place, is that now corrected, or is it being corrected? If the reason we intubated them was because they were apneic, they stopped breathing, are they now breathing on their own? You know, that sort of thing. Quantity and thickness of secretions. We are not going to extubate or decannulate a patient who still has thick, copious, tenacious secretions. We need that airway simply for ease of getting those secretions out. Because think if you did remove the tube or remove the trach, and they still had this buildup of thick, nasty secretions, they're going to probably develop their own mucus plugs in their own airway. And so in that case, we probably still leave the emergent airway in. Upper airway patency. Is the upper airway open? Or do they have the ability to still move air? An example, epiglottitis. So the epiglottis is swollen, it's huge. Thank goodness we have an endotracheal tube going past it so we can still ventilate the patient. But the patient may look great and say, okay, I think we need to extubate. And we take the tube out, but the epiglottis is still swollen. Now they're not going to be able to breathe once you remove their airway. Or how about this? The patient wasn't ready to be extubated yet, but we did a very poor job securing the tube. And because of that, the tube lost its position. I don't want that to be my fault. You know, the reason the patient's in so much trouble right now is because I just did a crappy job securing that tube. So, securing of that endotracheal tube or tracheostomy tube is extremely, extremely important. And I'm not going to take a shortcut when I do that, going, it's good enough. No, it's not good enough. It needs to be good. Presence of an intact gag reflex. Again, can they protect their own airway? If secretions start building up again, do they have the reflex to be able to cough and clear their own secretions? Kind of leads to that last one, the ability to clear their own airway secretions. So we'll get into this more in depth later. There's going to be some numbers, some assessment things that we'll be involved in when we determine if the patient's ready to be extubated or decannulated. All right, so steps for extubation. Okay, now let's just say everything looks great. Patient's doing much better now. It is time to remove the endotracheal tube. So number one, assemble the necessary and needed equipment. I say have intubation equipment readily available. It doesn't mean like, oh man, I thought they were ready to extubate. Am I going to have to turn around and put this tube back in? Well, hopefully we don't. But if we do, that equipment is close by. I'm not saying we have to lay out a new ET tube, a laryngoscope and all that stuff. I'm not saying we're laying it all out, but I know exactly where that airway kit is or where that crash cart is, it's just right outside the door. I don't have to bring it into the room, because I'm doubting we're gonna have to put a tube back in. But if bad things happen suddenly, as soon as I remove the tube, I know exactly where the next airway is kept and we can get the patient reintubated. Oxygen therapy on standby. So because the patient who's being extubated was more than likely on a ventilator, the reason they were intubated in the first place, ventilators probably on minimal settings, but they're probably on some level of oxygen. Very rarely do we have someone on a ventilator breathing 21%. Well, I think the lowest I've ever had somebody on was 24% oxygen. Wasn't much, but 24%, okay. But when I get the tube out, I still want to provide them with supplemental oxygen. Usually we don't extubate and go straight to room air. Good luck. See you next time. No, we'll put them on something. We'll put them on a little oxygen. And so make sure you set that stuff up already before you even extubate. You've already made sure the flow meter's in the room, the device, whatever you want to select, nasal cannula, simple mask, whatever, it's already set up. I'll even turn it on and just leave it lying close to the patient, knowing once I get that tube out and get rid of that tube, that's going to be the next thing I'm going to do is put it on their face. Suction endotracheal tube, well, make sure that tube is as clear as possible, right? You don't want anything kind of left behind, so get rid of the stuff that's in that tube. And suction above the pharynx. So that could be Yankauer, but that's only going to go as far, what is the back of our tongue, so to speak, getting secretions. But we'll talk about this in just a minute. There's a special type of endotracheal tube that has a suction port that is located just above the cuff. So in that case, we can suction the secretions that way. Oxygenate the patient well after suctioning. So even though we're doing suction here, I'm still going to pre-oxygenate because I'm suctioning. But once I'm finished, God bless you, with the suctioning, I still will leave the patient on increased levels of oxygen, 100% oxygen, just knowing what I'm about to do, getting rid of that tube. So just kind of giving them a little buffer, if you will, with oxygen. Step number 4, deflate the cuff. Now when you deflate the cuff, so I said 10, 12 ml syringe to the pilot balloon line, pull back to remove all the air. Now what happens when you do that? What happens to the cuff? The cuff deflates. What do you expect to hear? Air leaking back or out around the mouth. That is what's known as the leak test. What we just did is we're assessing if there's a leak. And should there be a leak? Absolutely. There better be. But what if there's not? You removed all the air, you hear no air leaking back from around the mouth. The patient just failed their leak test. Because guess what you're not going to do? You're not going to extubate the patient at that point. Because what that's telling you is, in their airway, it must be swollen around that endotracheal tube. You know, using my analogy of epiglottitis, yeah, epiglottis is still swollen. That's why you're not hearing, even though the cuff's deflated, that's why you're not hearing any air leak back out the mouth.
It would only be swollen and not blocked by, like, secretions or something?
That's why we suction before, down the tube, and orally, and clearing everything out.
Okay.
So we've cleared all that stuff out from secretions, but you don't hear any air leaking. Do not extubate that patient. Because what's going to happen if you remove that tube, and their airway's now closed, there's no ability to get another airway back down there.
On step 1, should that be extubation, because we're going to be extubating them, versus intubation? Or you want to have stuff on standby in case?
In case.
Okay.
And then intubation stuff in case you needed to re-intubate the patient. But like I said, you don't think you have to assemble it all, because I'm really not expecting to have to re-intubate the patient, but I know exactly where that stuff is. Because if that stuff is there, and I extubate the patient knowing we need to re-intubate, I still have a resuscitation bag, I still have a mask, I can still ventilate them manually while we get that stuff set up and call whomever who's going to be doing the intubation, but it's not going to be me. But again, leak test, super important, super important. Sometimes you learn that the hard way. friends who are therapists who extubated the patient, they forgot, didn't do the leak test, or they've done X number of extubations and they've never had an issue, but that one time that they didn't pay attention and realized, oh shoot, I should have never taken out the tube. But let's say this is something that was ordered by the physician. Extubate the patient in room 101. Okay, I'm getting ready to do that, but then I don't hear the leak. All right, I'm not gonna extubate, and I'll let the doctor know, hey, they didn't have a leak when I deflated the cuff. The physician will appreciate that you didn't extubate the patient. At that point, we know that there's a good leak. They passed the leak test. Now I can get ready to remove the tube. But before I can remove the tube, what should I have to do? Make sure all the tape's off the patient. And I didn't do that ahead of time. I wanted to make sure the leak test passed, and if that's the case, fine. I can put the air back in, and then, okay, sir, okay, give me just a few more minutes here, and we're almost done. I can start taking the tape and stuff off. Once the tape is off and the tube's basically just hanging there, it's not taped anymore, then I can take the air back out and then get ready to pull that tube. But make sure you coach them on taking a breath and coughing.
So if they fail the leak test and their airway swollen, would you like reinflate the cup?
I would put that air that I took out, put it back in, and then let the physician know that the patient did not have a positive leak test. But in this case, they had a good positive leak test. We've removed the tape or tube holder, making sure the cuff's deflated. Now I'm going to pull the tube. But instead of just pulling the tube whenever you want to now, instruct the patient. I need you to take a big deep breath. Then I'm going to pull the tube. At peak inspiration. Okay, at peak inspiration. At peak inspiration, how are the vocal cords? Wide open. So even though the cuff's deflated, I still don't want to drag the tube out against cords that are closed. So when they take a big deep breath in, vocal cords open. What's the next thing they're going to do? They're going to exhale and they're going to close, or they're going to exhale and start to cough. And that's okay. I want them to cough. When that tube's out, I want them to clear any loose secretions that may be left behind that I wasn't able to suction out. Get rid of those things so they don't aspirate that down into their lungs. But please make sure, remove the tube at peak inspiration. Not the beginning of inspiration. You pull it out at the beginning of inspiration when the cords are wide open. They're still inhaling. Any fluid secretions above the cuff, they're pulling those all down in. So take a big deep breath in, peak inspiration, then I'm pulling the tube. And you know the next thing they're going to do, they're going to have to, because their lungs are full, they're going to have to exhale and encourage them to cough. And they probably will cough once they feel that irritation of the tube coming out of their airway. They're going to feel the need to cough. Encourage them to cough. Keep coughing, keep coughing. You have that yank hour close by, they bring anything up, you can clear that out of their mouth and clear that stuff out really well, as you're now putting their oxygen on. Textbooks always say, so as far as what oxygen device to put them on, I say, well, you know what FiO2 they were on previously on the ventilator. Try to match it with whatever the oxygen device is that we have available to us. But a lot of the textbooks will say, post-extubation, go ahead, put them on some oxygen, but run that oxygen as a cool aerosol or cool mist aerosol. Now I know all of us haven't talked about all the different oxygen devices, so I don't want to get into what that looks like just yet. But it is a device that will provide, and I say cool, we don't chill it, we don't lower temperature, it's room temperature. But we provide this cool aerosol. That cool aerosol is going to lessen the chance for glottic edema, swelling. And so that's probably a good rule of thumb to always say for a patient I'm extubating, and I don't want glottic edema, I don't want that airway swelling, which is a potential post-procedure complication of extubation. Just put them on a cool aerosol, and really no more than 24 hours, because again, if things happen, stridor happens, it's going to happen within the first 24 hours post-extubation. And then we'll assess the patient, making sure we auscultate not only the chest, but listen at the neck. You can hear maybe some very quiet stridor that way, or like I said with stridor, you might not even need your stethoscope to hear stridor. There's some things we could do if stridor is present, and we'll get to that, what we'll do in that example later. But we're always checking for it. I'll ask the patient, you can tell me your name. It's okay if they speak a little bit, that they're gonna be hoarse, they're gonna be sore, especially the longer they've been intubated. They say, can I get something to drink? Well, you know, we'll probably get you started with some ice chips first and slowly reintroduce that sort of thing. But once I kind of hear them talk, then I kind of gauge, okay, their airway's okay right now. And because they're probably so hoarse, so sore, it's okay, don't keep talking. I'm not gonna ask you a million questions. Go ahead and just, you're doing much better. Your family's out in the waiting room. We'll go grab them in just a minute and have them come in to see you once you kind of get the patient cleaned up. Because there may be some mucus and stuff kind of loose, hanging around. All right, those are steps for extubation. Decannulation, without getting too much into the steps of the procedure, just some different things when we're getting to the point of decannulating. We can switch to a fenestrated tracheostomy tube if they don't have one in already, again, to allow air movement to go back through the upper airway. We can place even smaller tracheostomy tubes in to kind of get them used to breathing more through their upper airway. Getting to the point, perhaps, and not always, but perhaps even moving to a tracheostomy button. Now the button keeps the surgical stoma open. Because if you take a tracheostomy tube out over time, it will begin to heal and begin to close. But in those instances, we want to keep the stoma open for the fact, just in case we have to put the tracheostomy tube back in. And we'll have to send them back to surgery to have everything, started all over again. So what's pictured far left here is a tracheostomy button. Again, this is probably not the best analogy, but it's an analogy I always have used because it just makes sense to me. It's not meant for the patient to breathe back and forth through this button. It's simply to keep that surgical opening in the neck from healing, from closing. I could still have a patient on this. Now maybe they're on a nasal cannula, trying to make sure they're doing okay. And if they do okay over the next 2 or 3 days, 1 or 2, 3 days, then maybe we can eventually get rid of this and allow the stoma, the tracheotomy hole to begin to heal and begin to close. But if everything looks great, but 6 hours later there's this buildup of secretions, or they're starting to be short of breath, we can still take this out and put the tracheostomy tube back in. Tracheostomy cap, that's the piece that kind of goes over and blocks so the air doesn't go back out to the tracheostomy. Be careful, because I have heard therapists, and I was just as guilty as everybody else, refer to this as a button. It's not the tracheostomy button. It looks like a button. It looks like a button on my shirt here, except it's called a cap. This is the button that actually goes in. And my analogy that I neglected to mention, it's like a cork. It's not made out of cork material, but it's like a cork. It kind of just keeps the hole open, but doesn't allow anything to go through it. But button versus cap. Now when it's capped, notice no cuff, air for this patient's moving through their upper airway, back and forth, back and forth. All right, let's see where I'm at now. All right, so starting around page 748, some special tubes, some alternative airway devices that we haven't talked about before. So this is found on page 748. The first one being an LMA, laryngeal mask airway. Now this is an emergent airway that can be used if we're having trouble intubating a patient the traditional way. It also can be used if we need to intubate a patient for a very short period of time. Anybody in this room or who you know who's had some sort of surgical procedure where they had to go to the OR and be under the care of an anesthesiologist or nursing anesthetist to kind of be out for a little bit, and they were, sedated, paralyzed, whatever, they had to be intubated in the OR, they were probably intubated with one of these and not your traditional endotracheal tube. These are quite common, these are quite popular, but they are short-term usage only. Short-term usage only. So you, as far as running across a patient in the hospital who has one of these, very remote, very rare. But there could be that situation where we couldn't intubate the regular way, the traditional way. Is there an alternative? Yeah, there's a million alternatives. This just happens to be one of them, an LMA. So it does consist of a short tube with a mask, can be thought of as a cuff. All right, it doesn't look like the same cuff on our endotracheal tubes or tracheostomy tubes, but this is a big giant cuff that's found on the end of this tube. Now this is the part that's inside the patient. This is the part that's going to be outside the patient. This will connect to our ventilator circuitry. It'll connect to our resuscitation bag here. It does have a pilot balloon that when you add air, it inflates this mask or this big giant cuff. Now when it's placed, notice where the opening is. Okay, so when I add air through here, air is coming out of this point. Where this mask or big giant cuff fits is right into the esophagus. Okay, so when it's placed, it sits right into the esophagus. Basically, again, when it's inflated, blocking the esophagus. Air will come out those side ports here and supply the trachea with that gas, oxygen, air, whatever FiO2 you select. It requires no additional equipment to place. It doesn't require a laryngoscope, doesn't require a blade, doesn't require a stylet. The only additional piece of equipment that would be necessary here is a syringe to add air to that cuff or mask. And it's not a 10 or 12 ml syringe. It could be anywhere from a 30 to 60 ml syringe. You have to add quite a bit of air comparing it to the endotracheal tube or tracheostomy tube. And help me remember to point out Friday, and you guys with Desmond, remind Desmond to show you Friday, how much air you should add is written on the tube itself. There's different sizes, there's multiple sizes, but it's written on the tube itself how much air is recommended to be added to that mask or cuff. When it's inserted blindly, using your index finger, sliding over the hard and soft palate to push it all the way down into position. Again, where is it going to end up? Sitting right into the esophagus. Again, using your index finger and sliding it as far down as you can. Now, when you insert it, the cuff has to be deflated. It won't slide very well if it's inflated. The cuff has to be deflated. You advance it into position all the way as far as you go, so it's sitting there in the esophagus, then you can add air to the cuff. Now when you do add air, be aware the tube itself may begin to rise out of the patient's mouth a little bit, but that's because you've added air to this. So it's kind of, this is expanding and kind of pushes the tube out a little bit. All right, so like I said, it does come in various sizes, all the way from very small ones for infants to bigger sizes for adults. Like I said, this is a temporary, short-term airway. Cannot be used in a conscious or semi-conscious patient. We know why, because of the gag reflex we would have. If we're ventilating the patient with pressures that exceed 20 centimeters of water, some of that pressure can still get into the stomach, so causing gastric distension. And it does not protect against aspiration. Even though we add a lot of air, the pressure is very high, it's sitting figuratively blocking the esophagus, secretions can still find their way up around that inflated mask or cuff and find their way into the trachea. So it doesn't protect against aspiration. If like I said, yourself or a friend or family member that you have to be with, they're going to have surgery, anesthesiologist comes in, starts asking questions. One of the questions they will ask is, do you have any reflux disorder condition? The patient says, yes, I do have gastric reflux from time to time. The anesthesiologist, like, okay, make a note of that. They don't tell you what the importance of why they asked that question. Those patients will probably intubate the traditional way with an endotracheal tube because of that very reason. You're at risk for reflux, you're at risk for aspirating if they use one of these. But you can ask, even if it's a loved one, are you gonna be intubating with an LMA today, doc, or, and they'll do it, cause they're never looking you in the eyes, they're writing stuff, very small personality when it comes to the patient, at least most anesthesiologists are, because their patients are always anesthetized, their patients are always knocked out. But that's something you'll definitely get their attention if you ask, are you intubating me with an LMA today or an endotracheal tube? And their question, they won't answer it, they'll say, what do you do for a living? Because obviously you know something. Then they will answer you. All right, that's the LMA. Double lumen airways, known as the combi tube. Let me go ahead and say this about the combi tube. This is an old emergent airway. Still's in the textbook, still could appear on a board exam question, but it is an older emergent airway for patients who cannot be intubated the traditional way. It is meant to be inserted blindly, so without a laryngoscope, without a blade, anything like that, inserted blindly into the patient's mouth. Now, there will be, when it's all said and done, there will be 2 tubes sticking out of the patient's mouth, but 1 tube that actually goes into the mouth. Now, what do you think? When you blindly insert this tube, because you aren't using a laryngoscope, where do you think the tube itself is going to end up? Esophagus. And that is expected that you're going to end up in the esophagus. And so when this, I think I have a better picture here. Okay, blindly inserted, that's what it's going to look like. There's 2 tubes sticking out. But notice it does have 2 cuffs. 2 pilot balloons, 2 cuffs. I forget why they color this one blue and this one white, but probably can figure it out a little bit better than I. If you add air to this one, this is the oropharyngeal cuff. The white one is that distal cuff. This is the end that you would expect ends up in the esophagus. Now notice the openings. There's openings here that represent this blue tube. You connect your resuscitation back to this blue tube here. The air is going to come out this end. And there's a blocked end here, and there's going to be 1 open end. That open end, if you follow it all the way, will be this tube. Okay? So let me show you the picture. It's better to see it when you have the picture here. So what's pictured over here is what we just described. If I blindly insert this tube down someone's mouth, down someone's throat, the tube itself is probably going to end up in the esophagus. That's what's pictured here. Remember, there's these 2 cuffs that you will inflate. All right, you'll inflate these 2 cuffs. I always start with the blue side, the blue tube. When you add your resuscitation bag and you squeeze that breath, the air comes out those side ports. This end is completely blocked. No air will come out this end. The air is going to come out here, okay? And you'll see the chest rise and fall. Now, let's say you're just special. You're one of the people that, when you blindly inserted this, somehow, without seeing it, somehow, you found the trachea. If that's the case, play the lotto. That's not supposed to happen. But let's say it happened to you. When you initially inflated with this blue tube, the air came out these side ports. Where did the air go? The esophagus. Okay? So you switch tubes. You now inflate this end. You inflate this end, where does the air come out? At the very end of the tube. Because remember, the blue side, this part here is blocked. So the air will never come out of that end. It comes out those side ports. But on this side, the air will come out all the way at the end. So no matter where it's placed, you still have access to ventilate the lung.
And do they determine this by auscultation?
Auscultation and visualization. Seeing the chest rise and fall.
Okay.
Seeing the chest rise and fall. This is an older emergent airway. When you think about our folks in EMS that on the side of the road in a ditch at night somewhere, they may still have to intubate a patient. I'll say this, in the hospital, we're spoiled. The lighting's good, the temperature's comfortable. I could raise the patient's bed to my height that I'm comfortable with, so I'm not trying to break my back. But the poor first responders that are out there in the rain in a ditch, car upside down, extracting some patient, and there's a patient who needs an airway, they could use one of these. And so, if, this is a big strong if you were to see one of these, it'd be in the ER as they bring a patient in who they couldn't intubate the regular way just because of the environmental conditions they were in. But they could easily place one of these. Again, older airway still has a place. However, this is what we would run into every time they brought a patient in with one of these, is when they're now in the hospital, we're in a much more controlled environment, we would take this out and intubate them the traditional way, the regular way, the preferred way. But we found every time we took this out, and again, which picture would we see most of the time?
The one with it in the esophagus.
The one with it in the esophagus, very good. And so when we deflate the cup and take the tube out, the patient was prone to vomit. Coming out of the esophagus, and now the patient's vomiting. Again, there's no airway, there's no way to protect, from aspiration, things like that. So this over the years has started to fall out of favor. Okay, this combi tube. So, and this is still mentioned in the textbook, so that's why I bring it up here. So instead, there is a new tube. Now what I'm about to share is not found in your textbook. I'm surprised, but it's not found in your textbook. And that's known as a King Airway, which is really an adaptation of the original combi tube. But instead of two tubes, you just have one. It is one single tube. Again, blindly inserted, no laryngoscope, no stylet necessary. It's blindly inserted, and it's expected that when you blindly insert this tube, where's it going to end up? The esophagus. So when it ends up in the esophagus, this end is completely blocked. No air, nothing's going to come out of here. Air is going to come out of this location. Two cups, but one pilot line. You add air to this pilot line, both cups will inflate. And so, assuming you pushed it in, it found its way to the esophagus, you inflate both cups, you can still easily ventilate and be able to supply the patient's lungs with oxygen or air. King Airway is what it's called, but this is not mentioned or found in your textbook.
But what is the difference between that one and the previous one when it comes to extubation, like the vomiting part?
I don't know if it's because this one doesn't go as far down as the combi tube did, but vomiting is less likely with this particular airway. But you want to know the problem with this airway? What if you're that 1 in a million person that places this and somehow you put it in the trachea? Well, you're not going to make the patient. You're going to take it out and try again to find the esophagus. Again, the thing we always say when we're intubating, better not be in the esophagus, better not put it in the esophagus. But in this case, we want this in the esophagus, right? But again, another emergent airway. When we need somebody intubated, we need somebody with an airway, but we can't, the traditional regular way is just not happening right now for whatever reason. And we said the other day, there are surgical airways, emergent, cricothyrotomy, things like that. But hopefully we don't have to go to that extreme. We could use one of these other alternatives. All right, be careful with this one. This is called a double lumen endotracheal tube. But guess what people always get this mixed up or confused with? The combi tube. This is not a combi tube. It is a double lumen endotracheal tube that is meant to be placed in the trachea. I wouldn't say that this is one of these alternative emergent airways when we can't intubate the regular way. No, this is for a totally different reason. This is not in the same classification as an LMA or combi tube or King Airway. Those that we talked about previously are, okay, I can't intubate the regular way, is there something else we can try? Okay, those were the previous three. This one, very specific, unique reason for it. But again, this tube does require equipment, does require a laryngoscope and blade, because you have to see that it's placed into the right spot. Does have to be in the trachea, but it is 2 tubes, one to ventilate one lung, the other tube to ventilate the other lung.
Would they be on different frequencies is why they would do that, possibly?
Yeah, we'll get to that, we'll get to that
Oh,
in a
okay.
second, but you're very good with
Other
that
question,
one.
how do they, obviously, do they have to have some other type of instrument as well to guide it, to make sure that it goes into the right, because wouldn't it normally go to the?
They are designed, and they do make different designs, one that is meant to go into the right, based on the shape and angle of the tube, one that is meant to go into the left, again, based on the angle and shape of the
Okay.
tube. So it just depends which one, we're using as far as where we're actually gonna place it. But for each of these, again, so you have one that's supplying one lung, one that's supplying the other lung. Completely separate ways to ventilate each lung independently from each other. Patients who have a significant unilateral lung problem. Really, one lung's fine, it's the other lung that's horrible. If I have a patient on a ventilator, again, and I'm providing this tidal volume breath, it's gonna go in and follow the path of least resistance. If I have one lung that's really, really bad, really, really stiff, really, really non-compliant, the air is gonna wanna go to the side where it's better, it's easier to inflate. I don't wanna overinflate their one remaining good lung and not get any air into that bad lung. And so in those unique situations, they don't happen very often, but in those unique situations, a patient will have to have what they call independent lung ventilation, where you actually have 2 ventilators for a single patient. One ventilator ventilating one lung, the other ventilator ventilating the patient's other lung. When that's always happened to me, I always ask my boss or my supervisor, do I get credit for 2 vents? Even though it's one patient? They always say no, it's one patient. But I'm doing 2 vent checks, I'm double checking both ventilators, actually count extra for something when it comes to my workload units. But no, so in your travels, if you ever hear the term, hey, I got a patient upstairs who's on independent lung ventilation,
I want to see that.
ask, get a second, can I go see what that looks like? To be able to appreciate it. It's few and far between that you get to see that. That's why I always say as a student, I try to mention things that are very rare, because you may see it next week and think, oh, that's a normal thing. No, you just got lucky. You were in the right spot, right time.
What would be a scenario or like a case where someone would
Need
Yeah.
unilateral? Okay, so we have a patient, they were the driver in a motor vehicle. They were crossing through an intersection and a patient ran a red light and T-boned them from the side.
Okay.
And so the impact they took was primarily to their left side, not so much their right side, and so they were hit from their left side. They arrive in the hospital, they're having trouble breathing, who knows what sort of broken bones or fractures or things they're also dealing with, but I'm just referring to the lungs. The lungs can develop a bruise. We don't call it a bruise, we call it a contusion.
Mm-hmm.
And so that patient's lungs absorb the impact of that vehicle crossing through the intersection. That lung begins to become non-compliant over the next 12 to 24 hours. They had to be intubated because their breathing was poor, and we noticed continuing over the next 12 to 24 hours, that lung on x-ray, that lung is getting worse and worse. And so when they're on the ventilator, again, same analogy, most of that breath ends up going to the good side.
So in that
And
case,
not the bad side.
they were originally just intubated normally, so you would remove that and then do that one?
And put
Okay.
double lumen endotracheal tube in to independently ventilate. Another example would be, what about a transplant patient?
Yeah.
What about a patient who is having part of their lung removed? Maybe it's a lung cancer patient, they're having their left lower lobe removed, or a portion of their left lower lobe removed. Again, and you want to put in the appropriate volume on the normal side, but you wanna put in a little bit less volume on the side where things were taken away, things were, again, things that are just affecting one lung. But remember, most of our disease, it's gonna take me a minute to come up with an example, most of our diseases, yeah, that one, but some of the other ones, I'm trying not to say it, some of the other ones, asthma, it's a bilateral disease, it's just not gonna affect one lung. But maybe, extreme example, patient has a horrible, horrible pleural effusion just on one side. That's a unilateral problem. Not to say they're gonna need this, but just to create another example of a unilateral lung problem, only happening to one lung. But like I said, don't confuse this with the combi tube. People do, and I understand why. They sound very similar. Or don't confuse the combi tube thinking this is what it is. All right, moving on. Oh, the double lumen was on page 749. I forgot to mention that. All right, so a few other things. Special airway equipment, a little bit different than what we talked about before. This is the special type of endotracheal tube that has subglottic suction made with it. Now, my group probably had a sneak peek at this on Friday, but I didn't point it out. I didn't say anything about it. Marwin, I think you were asking about it. Maybe Grace asked about it. I don't remember. Asked about that. We're not there yet. We'll talk about that later. Well, we're later now. So this is a standard endotracheal tube, but it has one additional feature to it that's nice. So has the pilot balloon, has a cuff, endotracheal tube in the trachea, past the vocal cords, but it has this additional piece to it. You can actually connect your vacuum tubing here, and it will suction all the way to right here, that area just above the cuff. And so remember, you're about to extubate this patient. And one of the early steps is suction out the tube very good, clear all that stuff out, suction out, use the yank hours. So the yank hour is only going back, say, to here, clearing any buildup of secretions. But what about any buildup of secretions here? Well, I wish there was a way to get to it, and I can't stick the yank hour that far down. We know what how the patient would react to it. But there's this port, this special port that if I connect some vacuum tubing, and I don't have to set it to -200. It doesn't require that much vacuum pressure, but I can clear up any secretions that have started to build or pool above the cuff. And some hospitals, they may have this continuously on at like 10, 20 millimeters of mercury. Not much pressure, just to make sure nothing builds up over time. But if I don't have it on continuous, that's one of the things I want to do regularly. And again, if I'm just doing it temporarily, I can attach that vacuum there for just a little bit, and it's only going to clear secretions that have built up here. I say this is $1 million idea that somebody thought of, and it wasn't me. Why didn't I think of that? It's not overly complicated. And why did I think of that? I could be retired on a beach somewhere right now if I would have came up with that. But nevertheless, the brand name of this particular device, and there's other manufacturers now, but you may hear it, they typically in the hospital don't refer to it as a subglottic suction endotracheal tube. It's too many words to say. They may say, oh, do you have the high-low vac ET tube? That's what they refer to it as. But that's a brand name. On the board exam, they won't use that name. They'll call it that, subglottic suction. And I'm trying to remind our second-year students that term, subglottic suction, because they're used to the term high-low vac endotracheal tube. But the board exam will call it subglottic suction. Again, that's suctioning that area located above the cuff.
They're gonna be on the exam.
Yes. I could ask it either way, to be fair. But when it's the board exam, the long, convoluted word there that's hard to remember. All right, a lighted wand stylet. So here's another way to intubate without using a laryngoscope. And again, I know we haven't done the lab yet. That's this Friday, of course. But you're going to find it's going to be challenging to get that airway open using that laryngoscope. But boy, I wish somebody would come up with some other way so I wouldn't have to do that. I have to do a few more curls to get my muscle comfortable enough to be able to hold that tube. They do make a product known as a lighted wand stylet. So what's a stylet? adds rigidity to the endotracheal tube, and it goes inside the endotracheal tube, right? Well, so does this. So here's the endotracheal tube, there's the cuff, there's the adapter. This is inside of the cuff, and it has a light on the end of it. When you place it into the patient, and you dim the lights in the room or turn the lights off, and you look at their neck, if you're in front of the trachea, guess what you see? This nice bright red glow. Let's say you're down in the esophagus a little further back. You don't see that nice bright red glow. So that's another alternative to the traditional intubation route with the laryngoscope and blade, to use a lighted wand stylet. What do you think this is called? Bougie. Okay. Maybe somebody come up with boogie or something like that. But bougie. This is a thin plastic rod, very narrow, not pin-like, but very narrow, that is over twice the length of an endotracheal tube. Now notice this, it slid inside of the endotracheal tube. So this could be used perhaps if we're having a difficult intubation, we're having difficulty getting the tube in the position. I can see the vocal cords, but I'm just having trouble getting the endotracheal tube inside of it. Because again, the endotracheal tube is going to be bigger in diameter than, say, this bougie. If, as you can see here, the bougie is inside of the endotracheal tube. If they can see the vocal cords and can slide this much thinner bougie past the vocal cords, then they can slide the endotracheal tube down the bougie and get it into position, and then remove the bougie from the airway. Sometimes they can even use this as a means to switch out endotracheal tubes. So if somebody already has an endotracheal tube in place, and it's in the proper position, but something happened to the cuff was ruptured or damaged, and you know we can't use that endotracheal tube, they can place this down the existing tube. There's centimeter markings on it, so you can see depth. Down the existing tube, make sure the cuff's deflated, slide the old one out, leave the bougie in place because you know where it is, it's in the trachea, and slide the new tube over it into its proper position, depth position, based on the centimeter markings, and then remove the bougie. So it's a way just to exchange endotracheal tubes without having to have the process of complete re-intubation. You won't have to use a laryngoscope or blade or anything like that.
I literally had not flipped the page yet on mine, and I just glanced up and then back down. I thought it was a dude fly fishing.
Can't unsee it now. Thanks, Jeff. All right, so from this point, I think most of everything else I'm about to share with you guys is not found in the textbook. And why they don't include some of this, I have no idea, because they're missing part of what we do when it comes to airways. So, there is video-assisted intubation, where we can use technology to kind of help us see what we're doing or what we're trying to see to place that endotracheal tube. There's different brands, so I'm not loyal to anybody's brand. Of course, they all have their different advantages and disadvantages. But if you look at this particular one, it's a laryngoscope. It's a type of laryngoscope that has what on the end of it? A camera or screen. So instead of me having to lift and look, I can simply look at the screen, because again, there's a lighting camera on the end of this scope that is looking, hopefully, if I'm in the right spot, at the vocal cords. And I can still slide in advance the endotracheal tube, and I will see the endotracheal tube suddenly appear in my field of vision, looking at the camera, place it past the vocal cords. Like I said, different brands, and you're going to see in due time the more popular brand or brands that are out there. They, like I said, they all have their advantages and disadvantages. Some I know disadvantages would be when the patient's exhaling, the camera fogs up. Damn it, that's a big problem. You know, all right, no wonder you didn't sell these things very much, because the screen gets all fogged up. So, you know, that's one issue we've had with some of these things over the years. But technology, again, if they want to sell this product, they're going to overcome those issues of fogging up the camera. Other things would be if secretions are in the way, maybe harder to see that way. But I can still use my Yankower and try to suction as best I can. Here's some others. You can see just the clarity of what we're looking at. And again, remember, I'm not having to lift the patient's airway up. Remember, what's my biggest concern when we try to manipulate the glottis is by rocking on the teeth. I don't have to lift this thing very far at all, because I'm not having to lift it so I can see, the camera's going to see, right? And as long as I'm looking at the screen, now these are obviously not mounted directly on the laryngoscope, but they're right next to the setup, so I can see, make sure the intubator can see. I've had students before that get all excited, they get to see one of these, and they turn it around so they can see, but the doctor, the RT over here, hey, I kind of need to see that. Okay, let me switch my position here so I can see better. Because they're the one that has to really be able to see with it. Here's another one. Again, any patient population would this work for. Again, clearly seeing the vocal cords. And of course, for those that want to demonstrate and show us how it really works or looks.
Oh my gosh, is he oh. Oh my gosh.
Glottis, past the vocal cords. Clarity of the picture's not of this video is not the best, but sometimes people with too much time on their hands.
For real.
But he's awake,
Yeah.
doing it to himself. Should be pretty easy. I'd say he's a respiratory therapist. He's an anesthesiologist. All right, so another thing, don't forget, through bronchoscopy. A bronchoscope can be placed down the mouth or nose, and you can look and see structures, including the vocal cords. So if you have your endotracheal tube slid over the bronchoscope, because the bronchoscope kind of shows what you're seeing, you could simply slide your endotracheal tube in position. Never forget, that's another way. Again, I still and I include it here with the video assisted, because there is a light on the end of the bronchoscope, so you are being able, using video to assist that process. All right, so last part here, difficult intubations. With approximately 5%, studies say, with approximately 5% of intubations being considered difficult, and in the United States, on average, there's 20 million intubations performed annually. That means 1 million times there's a difficult intubation. And watch, it's going to be one of your first intubations. Whether you're performing or you're assisting, it's going to be a difficult intubation. So, some things would be nice if we could predict some things ahead of time. One thing I want you to remember is this Mallampati score. Okay, that's something that could be done even before intubation. You know, coding patients, a little bit different story here, but a patient who perhaps is having an elective intubation, you could tell them to open their mouth, say ah, look inside there and tell me what you see. If you can see their uvula clearly hanging down, their hard and soft palate, you clearly can see down into the oropharynx, as opposed to score 2, score 3, or heaven forbid, score 4, where you can't see anything, who's going to be the more difficult intubation? Obviously the number 4. The higher the number, the more difficult the intubation is going to be. That's something you could do even before the intubation process. Like I said, if the patient is a code blue coding patient, that's a different story. We don't have time to sit there and check them out. But for an elective intubation, absolutely we can do that. All right, so
what would cause that? Someone just like has a small mouth? Is that?
it could be anatomical. I'll give you a few examples here in just a second.
Is that also related to sleep apnea?
It is. It's another score, and we'll talk about it next semester with sleep apnea. Who's more likely to have obstructive sleep apnea? The 4.
Mm-hmm.
So remember that. And that Mallampati score does come back, obviously, in another situation. But this one right now, just talking about intubation. All right, so as our, how do I say this, trying to be gentle, as our population deals with obesity, our waist size gets a little bit bigger, does that mean our airway is gonna be bigger and more open and more easy for us to see? Unfortunately not. So if you think about our population comparing generations ago, yeah, we're bigger now, so we're encountering patients who are bigger who become more challenging when it's time to intubate. For example, how easy do you think this gentleman would be to intubate? To put him in the sniffing position,
Very difficult.
without knowing what you think his Malampati score must be. I would say a 10. It doesn't go up to 10, it only goes to 4, but you know, extremely difficult. So you walk in the room and see this is your patient. All right, get ready. Can I go ahead and get that video assisted intubation already? Because I think I'm gonna need some of those other tips and tricks that we have. The traditional way might not be possible with this gentleman. What about somebody's teeth? Significant overbite.
Whoa.
You know, again, rocking on the teeth, can't do that. But if there's significant overbite, that may be extremely difficult to overcome. And maybe changes the way we intubate a patient. Appliances in the mouth. Sometimes, obviously, in a controlled situation, these things would be removed. But what if it's a code situation? What if it's a patient brought in off the street? Again, and they're coding, we're trying to intubate them. Couldn't these things break off, potentially be aspirated? What do you think we're looking at here? This is a fractured mandible. Remember I said my jaw was broken from here to here? That's not me. That was my jaw's hairline fractures. This is significant trauma. From what I have no idea, but significant trauma. Baseball bat to the face or pipe to the face, something. Significant trauma. Is this going to be someone easy to intubate when you have the jaw just kind of moving freely in your hand?
Would intubate on that?
If they needed
that
to.
much trauma?
If they needed to. Or is there some alternatives that
that
possibly
would
could be used in a situation like this? Maybe we try nasal.
Yeah.
Because of just the
I was gonna say that would not be
of
your
the jaw.
first option unless like absolutely.
Depending, again, oral intubation is always our first option, but then assessing the situation, realizing, okay, this way is not going to work.
Like trauma in the nose too.
This gentleman, he was in a fire, burns. Notice how swollen he is, how swollen his airway must be, how swollen his tongue, his lips are. How is he intubated? Nasally. This lady has a condition, microglossia, an enlarged tongue. She would be extremely difficult to intubate the traditional, regular way from this massively enlarged tongue.
And people with Down syndrome.
Folks with Down syndrome tend to have larger tongues. Diabetic patients could have this. Hypothyroid patients, infection could have this. What am I forgetting? Allergic reaction could have something, like this, where things are suddenly swollen, and boy, normal airway anatomy is a lot thicker, a lot more swollen to deal with. But this gentleman, he fractured his neck. Okay, so his head and neck are in a very fixed position. Can I put him in the sniffing position? Do I have any opportunity to really do any sort of manipulation or moving of his head or neck? Obviously not. How would we intubate him? I'm sorry? Nasal, blind nasal intubation? Okay, possible. Trach? Okay, possible.
Would putting the bed into Delaware help at all, or maybe that's at an angle?
It'd be better than the position he's in. I'll give you that. But they had to intubate this guy. I didn't think they intubated him.
Videoscope?
Kind of. How about a bronchoscope? So you can see, kind of close-up picture here, you can see he's still awake. Bronchoscope down, they're looking at the monitor, seeing where the vocal cords are, and there's the endotracheal tube is slid over the bronchoscope. And once they have the vocal cords in front of them, they can slide the tube down and watch the endotracheal tube go through the vocal cords.
They're using, like,
He was
switches,
awake?
but with the camera.
He's awake.
Oh, yeah.
He's awake.
Oh.
Again, can't move, don't move. What do you think we're looking at here?
Is that where they ripped out the vocal cords?
No, but that's a good guess.
Oh, okay.
Choke, someone got choked real hard.
Crushed larynx. Crushed larynx. And now we're trying to intubate. I'm trying to see the vocal cords. Now the vocal cords are behind there, but because the larynx is crushed, it's very difficult to see.
Crushed just from like an accident or something?
Crushed from crushed. Hand.
Okay.
What do you think we're looking at there? Very good. Epiglottitis. Epiglottitis. The epiglottis that usually is very leaf-like, just floppy, small, thin, how swollen it is. So where's the vocal cords?
Right under there.
Up under there somewhere. So here's the situation. What if the epiglottis continues to swell? Because the only way they can pass air right now is through this little narrowed opening. Okay, if it continues to swell, then they're not going to be able to breathe. So those are just a few different difficult intubation situations or scenarios I wanted to share. I'll show you where I got a lot of this stuff here in just a second. But let's go to some questions. All right, so first question. During extubation, the endotracheal tube should be withdrawn at what point of the breathing cycle? Is this going to be done at the beginning of inspiration, at peak inspiration, beginning of exhalation, or during exhalation? This is at B, at peak inspiration. Again, and why? The vocal cords are wide open, and the very next thing that's going to happen is they're going to next exhale and cough. All right, so the vocal cords will then begin to close. All right, so this one is B. Next question. What's the purpose of a cuff on an artificial tracheal airway, such as an ET tube? Is that A, to seal off and protect the lower airway? Is it B, to stabilize the tube and prevent its movement? C, to provide a means to determine tube position via radiograph? Or D, to help the therapist determine the depth of tube insertion? This one is A. And I know because of those channels it can form, we can say, but it doesn't truly protect the airway if there's channels that can form inside that cuff. I understand, but the reason we keep that cuff inflated is to try to protect the airway from anything that can fall down through. But again, it's not a perfect system. All right, I think two more questions. A couple more questions. Which of the following is the most common cause of airway emergencies? Is it tube obstruction, cuff leaks, unplanned extubation, or a defective pilot balloon? Tube obstruction. And of those different examples of tube obstructions, which one would be the most common? Mucus plugging, mucus obstructing the tube. So I can't emphasize it enough that we have to stay on top of our patients who have tracheal airways in place to make sure there's not a buildup of secretions inside of their endotracheal tube. It is our responsibility to make sure we do suction, we do check, and make sure that the secretions have not built up. I will share in the coming weeks ways we can try to minimize or prevent that stuff from happening, but I still need to make sure I am always checking my patients with some sort of tracheal airway, whether it's an endotracheal tube or even a tracheostomy tube. They can plug tube, they can occlude tube. My last question, what's wrong with this picture?
Right
It
hand.
says all intubation nightmares begin the same way.
Wrong
They're using
hand.
their wrong hand, right? What hand should hold the laryngoscope? The left hand. Remember that on Friday. Please remember that on Friday when you're going to intubate, because it's a habit, especially if you're right-handed. You're going to say, no, my stronger hand's this. I want to use this hand to lift. No, it has to be in this hand. And trust me, on Friday we will practice with it to get you comfortable doing that intubation. In case you're curious where I got a lot of those pictures from, some of the websites that are listed here is where I was able to pull some of those pictures. So you can go and kind of peruse their site and see some of the different things they have on there, or options or offers they have on there. Again, these are not my sites, I don't control them, I'm not responsible for what's on those sites, but in case you're curious where I got some of those pictures from, it was these websites. All right, questions? Sure.
For the, so the buttons on the trach,
Mhm.
they keep the hole from healing, and
Correct.
they can't breathe through.
Correct.
Can they breathe through with that?
No, the
They
cap,
can't do that one.
so they still have the tracheostomy tube there. The cap just simply blocks this. For example, if a tracheostomy patient wanted to force air through their upper airway, cuff is deflated or there's no cuff, they could cover over this and force the air back out, so no air comes out their tracheostomy tube, but the cap is there so they don't have to do that.
And the tube is still in there, but the button, the tube is not in there.
Correct. Any other questions? All right, so I know the Airway chapter was a lot of stuff, and of course I put my 2 cents in and add some more stuff to it. But the lab this Friday will be exciting. It's always fun to do an intubation lab, but remember, you're also going to be looking at some of those alternative airways, like the LMA, Combi tube, Kimi airway. I'll have all those available for you guys, plus tracheostomy tubes to look at. All right, I have 11:11 right now. We'll start batch at noon. I did want to mention there is a food truck downstairs that supposedly is here from 11 to 1. I should have wrote down the name. I read it and I'm like, oh, I'll kind of remember that. I can't remember, but I know they have wings, egg rolls, shrimp, fries, desserts, all kinds of cool stuff too. So that should be here now, but we'll start back at 12, our normal start time.